Okay, so thank you so much, Dr. Muhammad. I'm very happy to be with this very nice group. I know it's late for a lot of us, so I'm not going to
You are
be
still in the
long.
home, no problem. You can go ahead.
Yeah.
Everybody is
Uh,
sitting in bed.
so as I mentioned earlier, I am not very um, I'm not very experienced with I'm new to ILUVIEN, and it just recently got approved by the insurance companies here, so we started using it just recently. So I'm going to show you a few cases, couple of cases actually, very quick ones, to illustrate a couple of points that I started learning from them. And then I'm going to show you a case which is really an unknown or a mystery case, which I will appreciate your participation with, and hopefully this will keep everybody awake. So let's go ahead and start with the first case. This is a 62-year-old female. She is type 2 diabetic, pseudophakic, and she has the history of using Ozurdex in the past, responds well to it, but well only for 3 months, unfortunately, never really gets any better. So this is a picture of her right eye, and after Ozurdex, she gets like this. Then a few months later, she gets another edema and gets another Ozurdex, she improves. So the typical story, and by the way, she has the same exact thing happening in both eyes, but I'm just sparing you the agony of seeing the other eye. I'm just showing you this here. So this is her pictures. Like I said, this is the beginning of this year, where at that point I discussed with her, because now it became available and her insurance covers it. Like, how about we actually shift to the to ILUVIEN? And she accepted that, and luckily we performed the injection, and she actually improved. It took about exactly what Abdullah was saying. It took about 6 weeks to see this kind of OCT, and I think this is probably the typical patients that you can easily start shifting into ILUVIEN, because they demonstrate a very good response to steroids. And unfortunately, Ozurdex, we know in real life, doesn't really last more than 3 months, maximum 4. So it is actually a very good candidate to switch to ILUVIEN. The second point I want to make in this case, which is case 2, 72-year-old gentleman, pretty much the same idea. He gets a lot of injections and every 3 months and gets excellent response. But I want to show you his pre-ILUVIEN injection, and then this is about 8 weeks later. He still has edema, and you know, at this point, I've decided actually to just observe him, because he reported a significant improvement in his vision. And also, I've had the fortune around putting this injection in. I had the fortune of discussing ILUVIEN with a lot of friends that have experience in this, and they told me just you know, wait a little bit, give it some time. And sure enough, actually, he is improving visually. Now, unfortunately, he called me yesterday. He doesn't want to come to get his eyes checked because of the COVID-19 issue. But I think the point I want to make with this presentation, with this particular case, is that I think it's a totally different response to expect than what we're used to from Ozurdex. Again, because of the difference in the dose. So don't expect them to get better. I think the case that Fahad presented is probably unusual in the sense that it improves dramatically, becomes totally back to normal within 1 month, which is amazing for this lady. So this is basically what I want to talk about as far as ILUVIEN is concerned. This case here now, I want your input on, and participation too, if you don't mind. You can participate by sending your comments or by speaking, depending what Dr. Muhammad Amri wants us to do. So this gentleman, 44-year-old, was referred to me for a vision loss in his right eye. He was recently, the only thing significant in his history, that he was recently admitted to the hospital for acute hypertension, which was put under control. And then during his hospital stay, he mentioned to his doctor that his vision in the right eye was changed. So they referred them for evaluation. Actually, they sent him to an ophthalmologist who referred them to me. No diabetes, no history other than hypertension. So I'm going to show you now his fundus photo, a series of the photos. So this is his right eye, obviously. This is the infrared picture of the same thing. This is the red free. And this is like sort of an overview of what you would see kind of like in a wide field photography. So I think this picture here, the previous one is really very interesting. Although, hold on for a second, this one here also is quite interesting and helpful, I think. So let's start, I guess, with our friends in the panel here. Any thoughts, any ideas, any questions you want to ask? It's muted.
Fahad from the UK. What's his full blood count?
His, sorry, what?
His full blood count.
Full blood count. Normal. I mean, his CBC is pretty much normal.
So no platelet issue, no pancytopenia.
No. Good question.
What's his racial background?
Filipino.
Could this be polypoidal?
Excellent. Could be. I don't know. Does anyone want more investigation?
ICG?
Okay. It's your lucky day, Dr. Fahad. So first of all, let's go with the OCT first. So this is the OCT showing the section in the center. This is another section up here. So can I just describe this, if you don't mind? I think what we're looking at is multiple layers of hemorrhage, right? So we have pre-retinal, intraretinal, subretinal, sub-RPE even hemorrhage all at the same time. So I think this is a nice clue. Okay, so this is the left eye. I thought somebody might ask, can I see his left eye? This is his left eye. Okay.
Okay.
And
if you have done any CT scan for this patient, Dr. Ammar, CT scan or
of what? Of the head? No, I have not.
Orbit.
Yeah. No, I have not. I have not. Okay, so we booked him for a, like I said, this is his picture here when I saw him, and we said, okay, you need the fluorescein angiogram and ICG. Let's get the approval. We got the approval within literally 24 hours. He's an Emirates employee, and he came back after for the FA, and basically now he has hemorrhage everywhere. There's barely any ability to do anything. Despite that, I said, let's just go ahead and see if anything lights up. So this is his early. On your left is his fluorescein, on your right is his ICG, and you can see that this is his early and this is his late. So now what? So I'm going to give you some treatment options. Inject anti-VEGF, inject Ozurdex, inject ILUVIEN, or do something else.
I would inject anti-VEGF.
Something else.
I would inject anti-VEGF.
Abdullah and Fahad will inject anti-VEGF, okay? And Dr. Muhammad is...
No, we don't know what is going on for what I will inject anti-VEGF. This is my opinion, I mean.
Okay. All right. Shall we keep going, or shall we look at the question and answers here? Is there any suggestion from anybody?
So can I just ask a question, Dr. Safar? So,
yes, sir.
So there was nothing lighting up on the ICG or the fluorescein to give you even a clue.
Well, I think there was some hotspot, isn't it, Dr. Ammar?
Okay, let me just go back for you. There was actually a something lighting up, yes, but let me see, how can I do this here? There. So you can see something lighting up.
Exactly.
But I couldn't tell exactly where is that really because of the blood. I couldn't see anything. Now, I peeked into the questions here. I mean, the question and answer. I just peeked into it right now, and I think a lot of our audience here kind of like alluded to a diagnosis, which I think is correct. This is a bleeding macroaneurysm. So basically, yeah, and the clue here is the bleeding in multiple layers. When you have pre-retinal, intraretinal, subretinal, all at the same time, is usually the clue that this is a macroaneurysm, especially with the history of recent hypertension. So I wouldn't inject any of these. I actually, especially with his vitreous hemorrhage now and hand motion vision, I took him to surgery. So when I went in, I cleaned up the vitreous, of course. It was really dense at that point. His vitreous was very hard to, clean up, and he's young, relatively young. And then you could see actually that there was a macroaneurysm. This is his post-operative. You can see this area to the temporal part. It's RPE blood, which I, of course, elected not to touch. But there is here, you can see the macroaneurysm. This is artifact, there's nothing here, but there is a macroaneurysm here that kind of bled all over and resulted in this picture. So that's basically a bleeding macroaneurysm that can again, the clue here is bleeding in all layers. I wouldn't recommend draining this part here because you're really going puncturing the RPE, which you will get into so much pathology and so much morbidity if you do that. One other thing that I've seen a lot of macroaneurysms in my career for some reason. I don't know why, but one thing I would also caution you with bleeding macroaneurysms when bleeding happens like this is you could potentially develop a macular hole because of the sudden accumulation of blood underneath the ILM. You actually can create a macular. I've seen 4 cases in my career of macular hole, but just from bleeding macroaneurysms. And this is the picture here. And thank you so much for your attention and stay safe.
Thank you very much, Dr. Ammar. Especially the last case, it was very, very interesting.
That's a brilliant case, brilliant case.
I have one question, Dr. Ammar. For the last, whenever you decide to go, you are having in your mind already that there is a micro aneurysm, or you are still, because we didn't see any real clue except only from the picture, you thought maybe a multiple, but it could be another, right?
Okay, so if you remember the picture of the very first, when I saw him with multiple layers, but the vitreous was still clear, I kind of thought that I knew that this is where it's coming from because there was this clot coming out of the superior arcade. But I wanted the angiogram to be done. Unfortunately, the vitreous became very hazy before we could actually do the angiogram. But yes, I was going in 99% sure that this is what it is. But of course, at the same time, having to be careful that it could be something else. So I was ready to kind of like vitrectomize him and inject him if I find that there is no macroaneurysm. And this could be just a breakthrough vitreous hemorrhage from a polyp, for example.
Actually, it was a very great meeting, and we are having a very, very interesting cases and presentation from well-known figures in vitreoretinal, from Dr. Ammar to Dr. Abdullah and Dr. Fahad. We are having a lot of questions. I don't know what can I ask, but I do prefer to have those friends, they want to talk. And I will start by Dr. Ahmed Al-Khashab. Please, dear friend, Dr. Ahmed Al-Khashab, one of the founders also of North Emirate Dubai Retina Group, and well-known also vitreoretinal surgeon here, like Dr. Ammar. Can we also open for Dr. Ahmed? Please, Dr. Ahmed, you are on live.
Assalamu alaikum, Dr. Muhammad. Dr. Fahd, excellent presentation. Dr. Abdullah, Ammar, as usual. I had actually multiple comments on all the presentations, but I would rather be quick. The last presentation by Dr. Ammar, the one with macroaneurysm, had actually a couple of cases like this one. And yeah, there was the clue with this clot coming out and the hypertension, malignant hypertension or sudden rise of the blood pressure. Yes, I agree that we should not be injecting without having a clue whether what we are doing, whether the injection would be beneficial or not. One more comment about the ILUVIEN. I think it is a great drug. I had an experience with just a few cases, maybe 5 or 6 cases up to date, but all of them, they are responding very well. One more comment is, as Ammar mentioned, I didn't see the sudden effect of the ILUVIEN within 1 month. I think we should give it time, at least 2 to 3 months to start having the effect. And we should tell our patients from the start that we would not be expecting a great and sudden improvement in visual acuity and central retinal thickness, because this is a long-term treatment. And it is very effective in chronic DME, as Ahmed Al-Barqi just mentioned in his comment about Dr. Mohammed Al-Malki from Saudi Arabia, that yes, even if the Ozurdex is not working, sometimes ILUVIEN would work. But after thorough examination of the OCT and making sure that there is no element of traction or taut posterior highlight. So we can give a chance for the ILUVIEN, and if it still persists in such case, I would consider still keeping the ILUVIEN inside and go ahead and do vitrectomy like Ammar mentioned. And I would like to thank you all for such a great meeting. And we are lucky actually to have this interaction from all over the region, from Saudi Arabia, from Lebanon, and definitely from here and from Oman with Dr. Mohammed Al-Abri. I don't see all the names, but we are fortunate to have all of you with us tonight.
Thank you, Dr. Ahmed, for your comments. Also, we are having Dr. Hassan Bahrani from Arbil, Al-Iraq. So now we'll have Dr. Saad Wahib from Saudi Arabia. He will have questions. I want just please, if you don't mind, dear colleagues, just we want to be very fast because we don't have a lot of time. We are having only 12 minutes and we didn't cover all the questions. We are having 34 questions still there. So I will ask, yes, Dr.
Assalamu alaikum. Can you hear me?
Yes, we can hear you very well. Yes.
Great. I just want to say hi to everybody. Stay safe. All our friends, Abdullah, even we're in the same city, we still don't see each other. I hope you all stay safe. I have a comment. I totally agree. If you look at the first picture of the last case of Dr. Ammar, you can see supraretinally the 3-layer hemorrhage, which I think indicates clearly that this is macroaneurysm. We do see some cases here, and interestingly, I think it's a bit more common in the Filipino race. I'm not sure why, but I've seen at least 3 cases like this, and depending on the degree of hemorrhage, you would probably decide to intervene. My question to Dr. Ammar, did you have to use any intraocular tamponade? And if you did, what was it?
No, I did not. I'm sorry.
Oh, you did not?
I'm sorry.
Okay, that's great. That's great. I totally agree with the fact that ILUVIEN will take some time. We have some limited experience, but I think this is where combination therapy will be very useful. Thank you again for.
Thank you, Dr. Saad. Thanks you. We are happy that we are having questions. So we can get. Okay, we can have now Dr. Kavita. Dr. Kavita, please. Fast question, please. It's a long, I know everyone is looking to his watch, especially Dr. Ammar. I can see him, he's going to sleep while he's...
Dr. Amri, actually my question, I'm so sorry.
Yes, Dr. Kavita, please.
Yeah, sorry, actually the question was before when he was presenting, actually I was wanting to ask, since it is a multi-layered hemorrhage, which is kind of pathognomic for retinal artery macroaneurysm. I just wanted to ask about that and also any systemic associations with it. So it was an earlier question, I'm so sorry.
Okay, thank you, Dr. Kavita. Now we'll have Dr. Prasan Rao. Yeah, please fast if you can. Then prepare, please, Dr.
Can you hear me?
Yeah, we can hear Dr. Prasan. Yeah, go ahead, please.
So I had a question to Dr. Fahad. I think he's already answered it. I had asked how many patients required anti-VEGF treatment when they were on ILUVIEN. I think he's already answered. He said 30% of the patients.
Yeah, 30% of my patients. Yeah.
Thank you.
Thank you.
My pleasure.
Thank you, Dr. Prasan. Also, Dr. Prasan, a well-known also vitreous surgeon in Dubai. Dr. Kavita, also a vitreous surgeon in the Ministry of Health. We are having still, I think, many questions, but I have, I don't know. I will give very fast for Dr. Hassan Bahrani if he's having a questions very fast. Hassan?
Yes, actually, there was no question. Thank you very much, everybody, for this wonderful conference. Appreciate it.
Thank you, Dr. Hassan. Dr. Khalifa, if we have Dr. Khalifa, please. Also, again, I think he's having a comment. Is there a question?
I have a question on the last minute. What are you doing, guys, nowadays? Are you doing these injections and this COVID-19 crisis, or you still postpone the patients, or what are you doing in the real world now?
Okay, let us have a quick answer from each of, because we are in different area. Dr. Abdullah, then Dr. Ammar, yes, Dr. Fahad then. Yes. Dr. Abdullah, did you stop injecting, for example, or you continue? What is your plan now in coronavirus situation now? What are you doing regarding
this is a very good question, actually. Since the COVID-19, there is a lot of difference regarding which case is elective, which case is urgent that you have to proceed on. The elective definition, most of the controversy is in injection. So we'll find a lot of guidelines has already been there in the market. French, UK, Dutch, German, American. So I believe, in my opinion, that all injection, you can delay it for 2 to 3 months till you get a space to inject those cases. Because in most of the time, the curfew is gonna be like in a very, very peak. Then they will decrease the curfew, so you refresh a little bit and you see the urgent patient in which you can inject. Then there will be another peak that you cannot inject. If you want to divide it to 2 parts, I will divide it to AMD, that it's better to inject because of the irreversible damage that the patient may get it. And the other, which is soft, is the diabetic macular edema, especially those who are already controlled, getting injected already before. I can delay them for 1 or 2 months with feeling comfortably.
Okay, thank you, Doctor. Any other comments? Same comment or different, Dr. Ammar?
Similar. I mean, I agree about diabetics. We typically could not easily, but more relax injection schedule, so could delay them. I just want to say that what we're doing a little differently with the AMD patients is that we have them not wait at all. So they come directly from the entrance of the hospital to the injection room, get the injection and leave. So that will minimize any waiting time for them. And we make sure that they wait, they basically have no waiting time whatsoever, so that they don't mix with other patients.
Okay.
Do you see him post-op?
No, we do not see them post-op. We see them after 1 month.
Okay, Dr. Fahad, you have any other comment? Or
no, it's very similar to along the lines of my colleagues. So in Sheffield, all of our AMD patients, we injected them in a week. So we did lots of lists to inject these patients in 1 week. And then we're planning their next batch of injection in 8 weeks' time. The other group that we were worried about were the CRVO patients, where they can get big drops in vision. But our DMO patients, if they weren't needing treatment, I was automatically deferring them. If they had treatment recently, I would call them and I would determine on a case-by-case basis. The vast majority, I was comfortable to defer because they were subjectively very comfortable with their vision.
Okay.
There's been the odd patient where I have treated them because they've been quite affected by the visual disturbance from their diabetic macular edema. But as a rule,
Dr. Fahad,
the AMD I'm prioritizing.
Okay, we want to be very fast in answering because still we are having only 5 minutes. I think we are having Dr. Patrick for questions, or if you want, Dr. Patrick, please. I received message that Dr. Patrick want to talk. Yeah, please, fast. I have one questions actually, or a comment about the giving, because from my experience with using ILUVIEN, till that Dr. Patrick ready.
Good evening for everyone. I thank you and your colleagues for your nice presentation and the nice intervention. And I'd like to ask Mr. Safar, Dr. Safar, what about the persistent macular edema, for example, exudative macular edema, especially exudate at the center of the fovea? Thank you very much.
Okay, Dr. Ammar, this question for you, please.
So I'm not quite sure I understand exactly.
He
He asked about
if
the
there is a persistent edema in the central with hard exudate in the center.
Yeah.
Okay.
Well, we all know, I think, from our experiences and from studies, that exudates will take a long time to actually go away when edema responds, but the exudate may actually take longer. So I typically, those patients will continue to keep them on monthly injections and monitor them and make sure that the exudate is actually reducing. If there is any identifiable microaneurysms in the perifoveal area that could be potentially lasered in a focal, modified focal, then I would combine that with the anti-VEGF.
Okay. I think we are having, I don't know, can you hear me, John, and team, Marvision team? Do we have more time, or we will stop on 11? Can I have information about this one? Anyway, I would like just to thank all dear colleagues, Dr. Fahad and Dr. Ammar, Dr. Abdullah. It was great to meet all of you, even virtually, but I'm very happy to see you all. And thanks for all our attendees and our dear friends that they have their comment either and or their questions. We are going to have also in the future a meeting, but inshallah, we are also preparing to be with CME accreditations. So the people, they can also benefit in a CME. We are trying this one, but it will be soon, inshallah. Nobody answered me, but we will continue till they inform me. I have one, cases actually in ILUVIEN. When you give a top-up, for me, I have several cases, and a few of them, they are getting respond very well in very fast. Some of them, yes, they are taking time to respond. But when do you think there is no response and you want to top up them? Is there a time, and what type of top up you want to give?
Shall I go first?
Yeah, please.
So, like I said, now I'm a bit more relaxed. So I would give so I've made a decision. This is refractory. I want to switch to ILUVIEN. I would wait 3 to 4 months. So long as I'm seeing a continued improvement in the anatomical profile or an improvement in vision, then I may not do any additional therapy. But if I see that there's a worsening compared to a previous OCT scan where there's been an improvement, if it's outside the FAS, then I would consider macular laser. But if it's center involving and it's a worsening and exacerbation, I would then consider an intravitreal anti-VEGF.
Yeah, I agree.
Okay, can I have a comment, Dr. Ammar? I think they give us a chance also to continue. No worry about that. Please, can Dr. Ammar, you have any opinion, or Dr. Abdullah?
It's the same thing. I would probably, again, I don't have very long experience, but I would wait probably 4 months or so, as long as we're not noticing any drop in vision. But that would probably be my time where I would intervene with an anti-VEGF.
I do the same, actually. Most of my cases, I top up after 1 month.
You top up after?
1 month.
After 1 month of ILUVIEN injection?
Yes, because patient has been waiting for 1 month before I see him and judging that he is not improving. So I give him another month after the ILUVIEN injection. If he doesn't improve, I give a top-up anti-VEGF.
You are not waiting, for example, 3 months to get the improvement?
For ILUVIEN, no, because of the same reason I'm saying the loading dose.
So you're really wanting to speed up the rehabilitation of that patient?
Exactly, because I believe time matter in macular edema as any other disease.
Okay, suppose I'm thinking about if there is a patient, it responds very nicely to ILUVIEN, then start also again. Sometimes you will find cases that after they are improving nicely after ILUVIEN, then start also having increase in the edema and start losing a visual acuity. What time, you have to interfere?
Whenever I see him get worse, I will inject him.
Okay. do you, Fahad or Dr. Abdullah or Ammar, inject and top up with steroid? Do you have any experience?
I have. I think that question was asked before. So there has been the odd patient where, I've given them ILUVIEN, they've been very dry and they've got a really bad, they had an exacerbation, say a year later. In those patients, they had absolutely no response to anti-VEGF. So most of the time it's an insufficient response, but they had no response. So I just gave them another steroid. They had a good drying with no increased problem with pressure.
Okay, Abdullah, I think you are loving that. Mean you are not interesting to give this. Okay, actually, I have a case. That's why I asked this question, because one time I discussed this actually with Dr. Fahad. I have one case and it was improving very well with ILUVIEN. Then one of sudden start losing the visual acuity and also increasing in the macular edema. But I found the macular edema very high. It's not, dramatically, it's increased. In this case, I top up with steroid. I don't have, any study about this one, but whenever I thought it's a very huge increase or of macular edema, I top up with steroid and it worked very nicely.
Yeah.
And then it continued. But I have another case, the macular edema, it was not that much. Then I top up only with anti-VEGF. I thought about they will respond maybe better. So maybe in the steroid tab, we need only to increase the dose or the steroid to be higher so they can respond very well. And both
I agree.
I agree about this one. This is my experience. It is a very small, some few cases, but still I do this one. This is my, and I was asking Fahad if there is anything that can support my thinking. We didn't find at that time, but we go for that, and it worked in this way. There is so many people, they are asking, about the ILUVIEN, if you can go directly and inject ILUVIEN as a first choice. Is there any cases that you do it as a first, naive patient with ILUVIEN or not? I think
no anti-VEGF challenge?
For you, because you are the one most having a lot of experience with that.
So in the UK, we can't give ILUVIEN treatment naive. They normally would get macular laser or anti-VEGF prior to introducing ILUVIEN. So I've only ever used it as a second-line agent.
A second line, okay. Because also there is also a lot of questions came or debate, because here in UAE we get the approval that came from FDA approved. I think the same for Saudi Arabia. That's why we have to give a trial of Ozurdex. But I think can be given as a second without using Ozurdex as an European approved, right?
Yes.
Okay. Is that also known, Dr. Ammar, or anyone who wants to comment about this one?
I think.
Go ahead, Abdullah.
Ammar, please.
I think in our market here, at least in the private sector, we have to follow the approval of the insurance, which follows the license. So our license here is we have to get a challenge, but it doesn't really have to be Ozurdex. It has to be a steroid challenge. So you can potentially just give them drops, Pret Forte or something like that. Unfortunately, I mean, this is one point I might actually want to make right here, is that don't always just immediately presume that if they don't respond to Ozurdex even, that they won't get any response. Like Ahmed Al-Bar'i said before, and I've had also cases where they do sometimes develop late response. So it's not a 100% guarantee, but yes, it does weed out a little bit of the ones that do have a response. And then the question begs the question. So, okay, let's say someone does respond a little bit and their pressure go up to 23, 24. Does that mean they're excluded? It's total contraindication for not giving them steroids, or is it a relative contraindication? I don't know. These are all debates that we can stay until tomorrow morning talking about if we open these kind of forms.
By the way, is there any contraindication for ILUVIEN? Anyone who have?
Yeah, I think if
glaucoma.
if glaucoma, uncontrolled glaucoma or infection, have to be very careful.
I mean, if someone is using steroid before Ozurdex, I mean, is after that there is a contraindication for ILUVIEN after giving Ozurdex? No.
No.
Let's say the question in another way.
Abdullah, I'll let Abdullah answer this one. Yeah.
Abdullah, okay, Abdullah, please. If there is a patient, suppose he is having macular edema, and you give anti-VEGF, then you give Ozurdex, and there is no pressure, and some patient there is a pressure. I mean, this is two groups. Okay, is there a contraindication to give ILUVIEN if there is if it is controlled or not controlled? So now it's 4 divided questions. Okay, Abdullah.
Yeah, actually, unless it is, if it's controlled, of course, I will give injections, and unless it is very high, uncontrolled, so I really will take care of his uncontrolled blood pressure rather than thinking of macular edema. Then whenever he arrived to a control level, I would inject him. As you see the video, patient has a glaucoma, I inject. Patient has a cataract, I inject. And I believe that those requirements is different between country and country. I mean, the guideline, the indication, different between country and country, like UK, it should be pseudophakic. In Europe, they don't ask you to do a steroid trial on it, or rather than Bridford, rather than Ozurdex, while in USA, they ask you to try Ozurdex before. So there is a difference between country and country. And I believe there will be in the future a change in the guidelines in which that you will feel more comfortable to inject even a glaucomatous patient or even a cataract patient. No one at the level, or let's say the most of those patients came for diabetic macular edema 10 years after type 2 diabetic macular edema. They have cataract by default in most of the cases. And I don't think this should be a reason. In some center in Europe, the first line is corticosteroid.
Yeah.
And if the patient doesn't improve, they inject him or top up with a corticosteroid, actually.
Okay. So
in diabetic.
Different comment about this one? Or can we go to another questions? We have one question also. What is the preferable? I mean, if you have a patient with a good visual acuity, and the one who is asked the question, he said, vision about 6/12 or 0.5 or better. And what is the criteria choosing here? ILUVIEN or Ozurdex or a grid laser? If there is any comment about this question from anyone.
Repeat the question again, Mohammed.
Patient with a good visual acuity and good OCT, and he's having still edema. What is the criteria to choose or to select between inject ILUVIEN or Ozurdex or to do a grid laser?
I would go for a grid laser in that patient. So if they've got mild edema with good vision, but it's just that if there's global thickening, I would consider a fluorescein, and I still use a lot of grid laser in my own care. I'm only really thinking about intravitreal therapies if there's central involving edema, obviously, and there's vision decline.
Okay, I mean, is there, I mean, different if you are selecting this patient, if it's a central or you are having somewhere, I mean, a site that you will do a laser. Suppose there is no site to do a laser, obviously. Are you still going to give a laser or you're going to give anti-VEGF?
So if there's central involving edema and they have good vision, I encourage all the panel, all the attendees to look at Protocol V, which is one of the latest trials published by the DRCR.net, which is the American Diabetic Research Network. In that particular trial, if you observe the patient very closely and only injected with intravitreal therapy, which was Eylea in that trial, when they lost 5 letters at 2 visits or more than 10 letters at 1 visit, the proportion of patients who were still 6/6 was the same if you treated them at baseline. So they were 6/6 with thickened macula and you treated them, or you waited the vision to drop. Those patients where you waited did not come to any additional harm. The proportion in the 3 arms was still of getting 6/6 was still equal. So I now feel very comfortable to watch those patients closely and only intervene if there's a decline in vision. But the point is, you have to watch them closely. You can't leave them for 6 months or 1 year. They have to be seen regularly in order that you can intervene at the right time. And for a lot of patients, that will come as a relief because you see the problem, but they are not convinced that there's a problem. So it's about waiting till it's the right time and giving it at the right time.
Okay, any other comments from another dear colleagues here?
I just want to add regarding, we should differentiate between the macular laser, between grid and focal. Grid, okay. I stopped doing grid since many years now. Focal laser, I'm doing focal laser whenever it's not central, as Dr. Fahd said.
Yeah, okay.
And as he mentioned regarding the protocol and most of the study, they talk that whether you inject related to the anatomical OCT or to the visual acuity, what you're gonna choose, which one? Better to have both, but sometimes it's become confronted between each other. I would believe the anatomical rather than the visual acuity because of simple reason. Most of the patient, most of the human being seeing better than 6/6. So if the patient came to you with a 6/6 visual acuity, but with a macular edema, it doesn't mean he doesn't have a deterioration in his vision. He may be seeing much better than 6/6, but he came to you with a small deterioration of his vision, then he sees 6/6 with this macular edema. Macular edema is not a normal thing. I would rather treat those patients who is 6/6, but he is believing on me if he has a macular edema proven by OCT.
Okay, Dr. Abdullah, I think this there is a debate about to give injection in a case of 6/6 visual acuity, because I think, I don't know, we have several cases, and I select for me and my dear colleagues, Dr. Abdullah, we are collecting several cases. They are having also a visual acuity, even drop little bit, 0.9 or 6/6 partially, and there is an edema, but we have to do a blood sugar control. We do this one for the patient. After 1 month, they came with no edema. So we are not, we don't need to go this is my opinion. And
it's a good point. It's a very good point. It is the osmolarity which caused the edema at the beginning, because when the patient has a lot of blood sugar in his blood, a lot of fluid shifted to the central circulation. And when he started the insulin or the anti-diabetic medications, you start to decrease the osmolarity by decreasing the glucose. Glucose causes osmolarity. This is why they urinate much. And when you decrease the osmolarity, the fluid shifted from the central to the peripheral, so he started having macular edema. I agree with you. Those who are newly diagnosed or those who are newly changing medications, we should be patient with them rather than rush for injections. But whenever I see macular edema, anatomical changes, I believe this is not normal. I'm talking about intraretinal changes, not subretinal fluid. As you know, subretinal is more safer than the intraretinal.
Any comment, Dr. Ammar, about this one?
No, actually, I agree with all the comments.
Okay. Is there anyone who raised his hand and he want to ask? I think Dr. Safwan, I don't know if he is still half or it is the same as before. I don't know. Dr. Safwan?
Hi, everybody. Just a small comment to Dr. Ammar Safar. Definitely a very nice discussion later on. For the microaneurysm, I have few cases, but luckily it wasn't subretinal. One of them is my relative. He present with the epiretinal hemorrhage, a dome over the macula, and it was very nice from one side microaneurysm from the upper part that leak to the subhyaloid. So it was subhyaloid epiretinal. So here I had the chance to do a YAG laser hyalodectomy in a way that the blood leak intragel and disappeared. And within 1 week, it was returned back to the normal. So just I need just to add this comment to the case that he present. And definitely I had two more cases that I had to do the vitrectomy for them, but luckily even they didn't have a subretinal. Thank you.
Thank you, Dr. Safwan. Thank you very much. You want to do any comment, Dr. Ammar, about that?
No, but I agree. You know, when the blood is only subhyaloid, then the option for YAG is definitely there.
Okay. I ask the friends here, team Marvision team, is there anyone who want to have a question, because most of the question answered. Is there anyone who want to ask a question? If there is, please, you can highlight and give the chance to ask. Otherwise, I think Bilal, we have Dr. Bilal Haj. Okay. Can we hear Dr. Bilal? Yes, Dr. Bilal. Dr. Bilal, yes. Open.
He's muted, actually. He's muted. Someone has to.
Yeah, I think they will open now. Please, Dr. Bilal, you can just remove the mute and open the mic and start ask. Dr. Bilal, if you can hear me, please. John, it's possible to open from your side?
Okay, I tried, but he needs to press
Okay.
it to allow.
Okay, so I think he is not able to ask a question. Is there any other questions? Any other want to ask questions? Okay, I think we are already more than 2 hours. It was a very interesting meeting. I would like to thank dear colleagues, Dr. Fahad, Dr. Ammar, Dr. Abdullah. Really, I was very happy to see you all. And also, I'm very happy that we hear a lot this meeting of dear colleague friends from different parts of our area. And it was very interesting. And we hope that we meet you also soon. And before we leave, we are going to have another meeting on 13th of this month. And we will have on 20 also and 2nd. And it will be, I think, the 22nd, it will be also with CME accreditation. So we wish to see you all again. Thank you for Alimera sponsoring this meeting. Thank you for Marvision team for helping us in this Zoom. And thanks for all. And good night and see you all.
Thank you so much.
Thank you.
Good night.
Thank you.
Yes.
Muhammad, Ammar, and Fahad. Thank you.
Thank you so much. Take care.
Thank you all.